Today's presentation is titled Overcoming Data Challenges to Estimate Whole Person Health in the Academic Learning Health System and will be delivered by Dr. Joe Rigdon and Dr. Sarah Lotspeich. Dr. Rigdon specializes in biostatistics and leads the Biostatistics, Epidemiology, and Research Design BIRD group, focusing on clinical trial methodology and lifestyle interventions. Dr. Lotspeich, an expert in statistical sciences, develops methods to address errors in observational data, particularly in health disparities and chronic disease research. Their work emphasizes innovative approaches to leveraging electronic health records for comprehensive health assessments, ensuring precise and equitable healthcare insights. We look forward to your talk, Joe and Sarah. Thank you.
Thank you, Metin. I'll go ahead and share my screen and jump right into it. So here we go. So as you said, our title is here. It's Overcoming Data Challenges to Estimate Whole Person Health in the Academic Learning Health System. For this talk, we'll sort of have 4 sections. I'll start with a background, giving everyone some context for where this work started. So it's resulting from 2 different pilots. Then we'll go into the methods and results, and I'll pass it over to Sarah for those sections, and then I'll conclude with current and future directions, kind of where we're thinking right now. Okay, so I'll start with a background. I think many of you know some of these statistics, but I've tried to provide references for all of these assertions just because I know that, these are changing statistics, and so references will be provided at the end. And the background is that, despite spending a lot of money compared to peer nations on healthcare, the United States has worse health profiles for diabetes, obesity, cardiovascular disease, and interestingly, life expectancy. And furthermore, there are drastic disparities by socioeconomic group and by race ethnicity groups for these health outcomes. This is also true in our local community, the Winston-Salem metropolitan area, and these trends have been made worse by the COVID-19 pandemic. So what can be done? Probably a lot, but a bit more background here. I think someone should be muted. Thank you. Thank you. So environment is very important. So there are some twin studies out there from Denmark that show that about 80% of life expectancy is determined by lifestyle. This primarily includes social networks, sleep, stress management, mental health, and of course, diet and exercise. And then interestingly, there's also research showing that lifestyle is largely determined by the built environment in which people live, and diets and exercise programs can be likely to fail. At the same time, over the last 10, 20 years, even now, I think this started with National Geographic, but researchers have been looking at these locations across the globe where people are living very long durations. So they're calling these blue zones. You probably have heard of them, different press outlets. So they exist in Costa Rica, Japan, Greece, Italy, and California. And the themes that they're finding among individuals in these communities, they've distilled it down to 9. I was looking at their website recently, and this is what they've most recently written, is that these communities have natural movement, they have a sense of purpose, they manage stress well, they control their meal portions well, they have a primarily plant-based diet, they have moderate alcohol consumption, a sense of belonging, strong family ties, and social networks that are supportive of healthy choices for all of the above. This kind of makes sense, pretty common sense. I will say caveat here that these studies have not been rigorously designed from a research perspective, so this is more maybe lower level evidence at this point, but nonetheless, the data do exist and it's interesting to look at. And so that's some backdrop for, well, how do we improve the health of our community? Many of you are working on many interventions to do so, studying various health outcomes. So this is certainly not new. I think what is new is what I'll get into in the next few slides, is that we need a way to measure comprehensively what's going on in our communities with respect to the general adult population and their health. So life expectancy is one way, chronic disease, of course, is another way, but these metrics can take years to develop, and we want to know if interventions we're piloting are working as soon as possible. So what could we do to gain some traction on this problem? Well, fortunately, others have been thinking about this recently. So there's this really cool metric that I would guess many of you have also heard of or worked with called the, let me do this slide first, called the Electronic Frailty Index. And so this is a measure of whole person health. It's designed for people age 65 and older. Piesky and Callahan showed that this measure can be calculated using a deficit model in the electronic health record. This is thanks to our colleagues at the Center for Healthcare Innovation. This is being calculated on a regular basis for individuals 65 and older, and I think maybe even 55 and older now. And we were wondering, with the goal of generally improving health, could we find a measure analogous to EFI, but that applies to the whole adult population? I'm going to jump back a slide and just talk a little bit about something I would guess we all know about, but inspired by the work on EFI, and just because it's there, we have this massive resource called the Electronic Health Record, or EHR for short. And this didn't always exist, but in the last 15 years, it has really started to explode, hopefully in a good way. And what this is every time we go to the doctor, health information is collected and recorded in databases. So this was accelerated in 2009 by the Obama administration, the HITECH Act, but had been going on in various places before and has really started to compile lots of data nationwide. And so this is a massive opportunity to measure many aspects of patient health, but also there are massive limitations as these data initially and currently, maybe more so for research, but at least historically have been collected in the fast-paced world of clinical care, and they're designed for billing and not necessarily research. So these are not, even though these are observational data, this is not a rigorously designed observational data with regular collection of data by trained study staff. This is not a research study as many of us are used to with cohort studies, and certainly no randomization here. And so these data are subject to missingness and errors. And let me go here. So in addition to the EFI, I was fortunate to work on a project a few years ago involving something called the Allostatic Load Index, or ALI for short. So you'll see that acronym in our presentation. So this is something that I believe arose in the late 90s. The researchers were looking at a cohort study and trying to do what we're trying to do with the EHR, measure whole person health, using a metric that's sensitive to current health state and is predictive of downstream health outcomes. And so the researchers defined the ALI using 5 body systems: the cardiovascular system, metabolism, the HPA axis, which is a measure of stress, the autonomic nervous system, and then inflammation. And you can check this on Google Scholar. There are all sorts of cool research studies that have happened over the last 25 years on ALI. Some of you may also have been involved with them yourselves. It's just a well-studied measure, and there's even some emerging research on applying it to the EHR, which is our goal today. And so the research that's been published shows that ALI is associated with subjective health, so worse self-rated physical and mental health among an EHR-based cohort, and also objective health, so higher risk for mortality among a representative US population. However, there's considerable heterogeneity in how the ALI is defined. So one of our goals with this work is to create an approach that can be easily and consistently used. And if we were to be successful at doing that, this is the way we're thinking with our original pilot, this could serve as a benchmark of community health state in Winston-Salem and provide value in a lot of ways to the academic learning health system. So with our first pilot starting in 2022, we were able to, in partnership with the CTSI, obtain pilot data on 1,000 individuals aged 18 to 65 who had at least one billed primary care outpatient encounter in the system in the 2 years prior to the COVID pandemic onset, which was March 11th, 2020. So we wanted to try to keep things simple in our pilot. We wanted to not, as much as we could avoid it, worry about COVID and just focus on data from 2 years prior and try to find a representative sample of our health system. So the data elements we requested included individual and community demographics here in this first bullet point, and then additionally information on all encounters in the EHR dating back to 3 years before their first encounter in this time window, so inclusive of visit type, vitals, lab values, discharge diagnosis codes, and problem lists. And we'll get into more of what those are as we proceed in the presentation, but I imagine many of you are working with those data right now in various capacities. So here's a table showing we have in the rows those 5 body systems that the original ALI researchers identified. Then we have in the columns sources of data in our EHR as we think about ways we could possibly create this metric. So you can see that there are 3 main sources of data that we're able to pull in working with the CTSI. Those included vitals, labs, and diagnosis codes or problem lists. And some metrics of interest are given here. So some usual suspects for vitals for cardiovascular, so blood pressure, heart rate, temperature. Then for the metabolic system, we have BMI and waist circumference. We have a variety of labs given here across the 5 body systems. So really, this is where most of the action was 25 years ago when they had the rigorously designed observational study where they could measure these 5 body systems with respect to these labs prospectively. We don't really have that, and so that's a big limitation with trying to, we don't have that, frankly. That's a big limitation with using EHR data, which I'll show in the subsequent slides. What we do have, on the other hand, is we have rich information on diagnosis codes in the problem list. So there may be other diagnosis codes and problem lists that we could pull into some of these empty cells here, but here were some of the few that we started brainstorming on with our clinical colleagues. So I want to show you some pilot data as some further motivation for the methodological approach that will eventually show you as a way around some of these challenges. But we do have great data on demographics. So we have relatively complete data on age and race, and then we have data on percent in poverty. So this is a neighborhood level metric linked from the American Community Survey. However, already towards the body mass index, we're starting to see substantial missingness. But the point of this slide is just to tell you that our 1,000 person representative cohort had approximate median age of 45. It was about 28% non-white. The percentage in poverty at the neighborhood level was around 12, and the BMI was around 29 for males and also 29 for females. So what I'm going to show you on these next 5 slides is our pilot data we were able to pull on those variables. If I jump back a few slides, I'm basically going to show you body system by body system what we were able to pull for the relevant ALI variables. So starting with cardiovascular, going to metabolic, stress or HPA axis, autonomic, and then inflammation. Okay, so cardiovascular variables. We only had, so these include blood pressure, so systolic and diastolic. We're about median 126 and 78 for our population of around 1,000. We have information on temperature, pulse, respiration, red cell distribution width. However, as you see highlighted in red over here, we have about 57% missingness for all of these variables. So when I first saw that, I was just alarm bells go up in your mind of like, oh my gosh, is this even going to be possible? What can we do? Maybe not. I mean, that's the nature of a pilot. Sometimes they don't work. And this was more discouraging information on the metabolic variables that, these labs, these glucose and insulin tests are only ordered for reasons. They're not taken at random. They're not taken on everyone. So we have missingness here, but we likely have informative missingness too. So very difficult research problem that we have 78 to 99.5% of the data missing for one of these body systems. The individuals with the missing data likely are different than those without. So, then looking at across the other three body systems, we started to get into the diagnosis and problem list codes. And here is where we actually were starting to make some progress. You'll see, if you follow my cursor, for these different ICD-9 and 10 based conditions, we only see about 8% missingness in our 1,000 person sample. And this made me realize maybe why EFI uses many of these variables potentially, and could we do something similar? However, the backdrop with ALI is it was really a biomarker-based index created 25 years ago, and one of our key biomarkers for stress, cortisol, is 99.4% missing. So that is an issue. Autonomic variables, we have the same observation where for the diagnosis and problem list, ICD-9 and 10 based variables, which are sort of given if you see my cursor all the way down to here, we again only have about 8% missingness there, but for our norepinephrine, which was, I think, the key metric in the original ALI study for the autonomic nervous system, this is only observed, I believe, in one person in our data set, so one female out of 1,000 individuals. So that was highly concerning. And then, the bad news continues on this slide. There will be good news coming, I promise. But with the inflammation variables, the data on inflammation, we were able to track down from the EHR in our 1,000 person representative sample contained about 67 to 99% missingness with respect to these different biomarkers that again have to be ordered via lab test. So we have a lot of missingness, and it's likely informative missingness too. And so I got to say, after seeing these data, I was somewhat discouraged at the conclusion of the first pilot. I was fortunate around this time to attend one of Dr. Sarah Lotspeich's talks, and she presented a topic I had not heard about called partial validation. So, of course, as a statistician, I was aware of multiple imputation, inverse probability weighting as ways to address missing data. But I think the recommendation there is the missingness needs to be much lower, at a much lower percentage than 68 to 99% to be able to really do anything analytically. And so I heard about this really interesting new idea from Sarah and her research group called partial validation. And she's going to tell you a bit about what that entails in much more detail. But basically, it's sort of this third bullet point. Could there be auxiliary sources of information in the electronic health record, for example, in the clinical notes or in other parts of the EHR that are useful for measuring ALI that were not captured by the translational data warehouse, which is where I was receiving data and working in partnership with the CTSI to look at variables related to this metric. One way to gain information on the missing data would be to do a full chart review or a complete validation of all of the 1,000 participants in our representative sample. And so this would entail hiring a lot of, or really me or others working in depth on every single person's chart and reviewing all of their encounters, reviewing all of their notes. This would be highly time consuming, certainly in the context of a 1 year long pilot. And so this idea of partial validation is, can we choose a subset of the 1,000, ideally in a data-driven sense, to gain information on, in some ways, the most informative individuals to our research question as an alternative. So we take the 1,000 person full data set with its missingness and errors, and we find the most informative subset, and we try to fill in the blanks and really do some deep detective work on these, whatever subset we end up choosing. So working with Sarah, we have a joint pilot that we've been working on for about a year now with the following three aims. And the overarching goal is to establish a framework to estimate ALI and its association with healthcare utilization using, again, this EHR data that are subject to missingness and errors. And to accomplish this goal, we had proposed the following aims. Aim one is to develop a shareable validation protocol for the EHR system here. And Sarah will tell you about what that means. And then aim two is to what I view as one of the most exciting parts of this project, to identify the most statistically informative 100 records to be validated. And then finally, towards the overarching goal above, to combine the validated and unvalidated data for robust, efficient analyses for estimation of this association up here. Okay, so that's where we've started, and that's some background. And with that, I'm going to pass it to Sarah, and I'll keep the screen sharing privileges. And Sarah, please just tell me next whenever you're ready.
That sounds great, and thank you in advance for clicking. I have to say, as the measurement error person on a project, I'm not usually the good news, so this is kind of a fun twist of fate. So Joe's done a really nice job setting up so far kind of the real world why. And so we have this original definition of the allostatic load index, or the ALI, that, as you mentioned, was largely developed and tested in these controlled settings where you could make sure that every patient had every component. And with that came kind of, I think, this luxury, well earned, but still, of including a lot more components. And so we wanted to start out by kind of simplifying our definition of ALI to focus on some key pieces. And so we adopted a simplified 10 component definition of the ALI from Seaman et al., I believe also in the 90s. And so this 10 component definition draws from 3 body systems: cardiovascular, metabolic, and inflammatory. And so basically these numeric components are all collected and observed, ideally in the EHR, and then to be compiled into the allostatic load component, they are discretized, or you could think of them as being made binary, based on these different clinically driven thresholds that, again, are well tested and validated in the existing literature. And so basically, you could take the numeric 10 components, translate each of them into a 0 or a 1, depending on whether or not the value was above what would be perceived as like a stressful threshold on the body. And the original Seaman et al. Calculation was then a count. So the minimum allostatic load for them would be 0, meaning the patient had not experienced any of the component stressors in their lifetime, and a 10, meaning they had experienced all of them. And so a big reason why this pilot came to be is that we have some of these things in the EHR, but there's also quite a lot of missingness. And even the things that are non-missing can have some error because they're collected, again, in this fast-paced world of clinical care. And so the first thing that we needed to do was decide how we wanted to adopt this calculation. It's not really fair for us to use a count in the way that Seaman et al. Did, because that's inherently assuming that things that were missing in the EHR were a no, or were a healthy threshold, and we didn't want to do that. So the first decision that we made was to compute the allostatic load index instead as a proportion of the non-missing component stressors that a patient had experienced. So basically, we add up the number of non-missing ones, and then we divide by the total number of non-missing components per patient. And this allows us to effectively kind of ignore the ones that are missing for now. And that means that our initial guess, or our initial calculation for the allostatic load index, is now a proportion between 0, meaning, again, a patient had experienced none of the non-missing components, or 1, meaning they had experienced all of the things that we could have seen happening to them. Next slide, please. And so our interest, in terms of kind of end of the day, a statistical model, is modeling the relationship between a patient's allostatic load index and their healthcare utilization, where healthcare utilization is an important thing to predict at 2 levels. For the patient, it's important that we maybe can find opportunities to intervene and apply preventative care. As an institution, it's also important because it allows us to make logistical plans. And so we're going to model a patient's likelihood of what I'll call engaging in the healthcare system, which more specifically means that they experienced a hospitalization or an emergency department visit in our 2-year study period. And we're interested in modeling this as a function of the allostatic load and other components. So my outcome variable Y is a binary variable: yes, no, they engaged in the healthcare system at least once in the 2-year period. Then I'm going to introduce X, which is our true version of the exposure. Can you click for me, Joe? It should just do an animation. So X is the validated ALI. We're going to assume that this is a measure of the ALI that is enriched by that additional information that Joe mentioned from diagnosis codes and things like that. This is obtained by clinical research trainees actually going into EPIC and reviewing these patients and trying to find basically auxiliary information. For example, if they were missing hemoglobin A1C, is there enough information in the chart to suggest that their hemoglobin A1C would have been above or below that clinically meaningful threshold? And so this is perceived to be, or planned to be, a better version than what we got out of the original extracted EHR data. And so this validated variable X is kind of, I'll call it an alloy gold standard. It's not the ground truth, but it's the best we can do in the given constraints. But the one that we actually get from the data warehouse that Jill mentioned is an error-prone version, which I'll call X star. And finally, we have the opportunity to include additional covariates. For now, we are just including age at the beginning of the study period, which means at the end of the day, our healthcare utilization model of interest is a logistic regression model for the odds of engaging in the healthcare system as a function of allostatic load and these additional covariates. And can you click for animation, please? Throughout, I'm going to assume that we are primarily interested in this relationship. We're primarily interested in the relationship between the outcome, engaging in care, and the validated allostatic load index, but we do think these additional covariates need to be included. Can you click, please? And so we thought that validating would provide a nice way of getting more information than we have in just the extracted EHR, but the reality is that these validation studies or chart reviews are expensive and time-intensive undertakings. This took months and a fairly generous pilot to make happen. And so in our study, we extracted, or actually Joe had already extracted in the previous pilot, 1,000 patients who were perceived to be kind of routinely engaged in our healthcare system. So these were people who I believe had at least one primary care or family hospital visit during the period. And so the pilot gave us the ability to validate 100 or 10% of the people in the original study via chart review, where again, clinical research trainees were given some guidelines and asked to go into EPIC and check the data points that we see in the extracted data. And so as a statistician, there are two really exciting opportunities that arise where we can make the most of our investment into these 100 validated patients. And first, this is through how we analyze the data. The second is through how we design the validation study. So for our analysis, we will not have validated data for all of the patients, but the unvalidated data for those other 900 patients is still incredibly valuable. And so we can adopt and will a robust analytical approach that incorporates all of the available patient information into our statistical models. Incorporating these patients is important because it helps us gain better statistical efficiency or precision down the line. So then the second opportunity comes in how we choose those 100 patients. And this one is kind of backwards because the reality is that how best to design the validation study depends on your analytical plan. So I'm going to adopt a certain type of method, and for the method I have chosen, there is a particular way to choose these 100 people to help me gain even better statistical efficiency or precision. And so these opportunities are importantly intertwined. Click, please. So to describe our analytical strategy, I'm going to start by describing a complete or a validated observation. So this is what we would observe for the 100 people in that validation study. Now, they're assumed to have the outcome Y, two versions of the allostatic load index, X and X star, and some additional covariates. And using some basic rules of probability, we assume that this complete observation is generated from a joint distribution, which can be broken down into the product of three smaller models, basically. And so the first model, P of Y given X and Z, is the healthcare utilization model that we are actually interested in. The second one is relating the validated and the unvalidated allostatic load and the additional covariates if we'd like. And this is important because it's going to allow us to leverage information gained from the validation study between the kind of before and after chart review versions of the variables. And so we're going to model this robustly, meaning I'm actually going to leave it unspecified and use kind of a data-driven estimate for this model. And now the third model is the joint distribution of unvalidated allostatic load and age. And in fact, click please. This one I don't have to make any decisions about because X star and Z are fully observed in the study, which means that whatever I assume for that model isn't going to change my ability to estimate that healthcare utilization model I'm actually interested in. And finally, maybe there was some probability folks in the room. I need to point out that that first, the leftmost term in that equation assumes surrogacy in the measurement error literature, which means that unvalidated allostatic load is assumed not to tell us anything new about the relationship with healthcare utilization after we've already included the validated version. And in kind of probability speak, this means that the conditional distribution of healthcare utilization given validated and unvalidated allostatic load and age is equal to just the model for healthcare utilization, validated allostatic load and age. Next slide, please. And so usually, if you had error-free, complete data and you were trying to model healthcare utilization in this way, you could do it by maximizing a log likelihood that looks something like this. So you would sum over all of your observations and it would simply be the log of that first piece. It would just be the log likelihood based on the first model. But the thing is, when we have partially validated EHR data, we have missingness in Xi. And that means that this model is kind of tangled up with that measurement error model, that second term that I was talking about. And so our log likelihood here is instead said to be an observed data log likelihood based on the missing data literature. And to take us through this just a little bit, click please. I've introduced a validation indicator, V sub I, which is equal to 1 if the ith patient was validated, so included in our chart review, and 0 otherwise. I do this on purpose because it allows the people who were validated to contribute that thing in the top line, and the people who were unvalidated to contribute the thing in the bottom line, where, click please, that top line is allowing the validated patients to contribute complete data since they have it. And click please, the second line is using, again, some rules of probability to allow the unvalidated patients to contribute everything that they can. They're still going to contribute incomplete data, and we're basically going to explain away their missing X values. And so there's existing software that we can actually use for this, and this approach to basically logistic regression with a robust measurement error mechanism has nice large sample properties that have already been proven. Which takes us now, click please, to our validation study design. So full likelihood approaches like the one I've described are really, I think, appealing because they're more flexible in the way I can choose my validation study. Earlier, Joe mentioned inverse probability weighting, which is a powerful approach to handling missing data. However, because of the way inverse probability weighting works, you can be somewhat restricted in who you can choose for your validation study. And simply put, for a full likelihood approach like ours, any information that is fully observed for everybody can be used to design the validation study. And that's because if I use, for example, Z, X star, and Y, or any subset therein, my X values from the chart review are still going to be missing at random, and the method will remain valid. And so the first option would be perhaps the most uninformative design, and that's just a simple random sample. I would take our 1,000 patients and I would just take a random grab of 100 patients. And so this is a valid choice, but it is perhaps the least informative, or it is absolutely the least informative way to choose this. Click please. And so another option, since we have a binary response Y, would be to do what's called a case control study. So I might take 50 people from those who weren't engaged in the healthcare system and 50 people who were engaged in the healthcare system, and you would validate half and half. So in this visual, the left-hand side is a stratum of people with no visits. The right-hand side has some visits, and you see that we're drawing even numbers of people with the darker shading from each of these strata. Now, the problem here is that we have additional information on X star, and we're interested in using it. Click please. And so you could also consider sampling on Y while simultaneously sampling on the error-prone version of the allostatic load index. And so one way to do that would be to take the numeric allostatic load index and you could create strata based on it. For example, I've now taken those left and right-hand strata of engaging and not engaging, and I have split them further based on whether or not patients had an allostatic load that was above or below the median. So I've now created 4 strata. And this can be helpful because it is at least making sure I have kind of enough high allostatic load and low allostatic load within the different groups. And you can choose these stratum size to be balanced. So I could choose 25 from each, or you can in fact find them to be optimal, which is something that was derived in an existing paper in the Canadian Journal of Statistics, I believe last year. And it has existing software. Click, please. But now the downside to any of these stratified approaches is that we're losing information about the individual values of the allostatic load. So in theory, without missing this, there should only be 11 possible values of the allostatic load index. It should be 0, 0.1, 0.2, and so on up to 1. But because in our case, everybody has not only their own numerator, but their own denominator, we see like 40 or 50 different values of the allostatic load happening. And so what we found was actually the most informed approach was to fit a naive version of the analysis model, which means I'm going to fit the model for healthcare utilization, but I'm going to use the EHR extracted allostatic load X star in place of X, which is what I really want. So then from this naive model, I can compute residuals for each patient in the original study, where since this is a logistic regression model, the residual looks a little different, but you take their observed outcome and you subtract off their probability of engaging in the healthcare system. So then I take these 1,000 residuals and I use them to rank patients from the smallest to the largest residuals. And so I tried to do this one visually as well. So we're back to a case where I have kind of two overarching strata, people who didn't engage in care on the left and people who did engage in care on the right. And now within my strata, everybody gets a little number because I'm ranking them by residual. And so basically the way that residual sampling, as we'll call it, works is I'm going to choose half of my patients to validate from the tails of the residuals. And so you can interpret this a little bit here to say that I'm going to take half of the validation study from people who didn't engage in care, but had a really high probability of doing so. And I'm going to take the other half from people who did engage in care, but had a really low probability of doing so. You're taking the people still who were kind of the most different from what the model thought that they were going to be like. And so this is the strategy we ended up adopting. Next slide, please. And so we split the validation study of 100 people into 3 waves. This was kind of logistically driven. We did this so that our audit protocol in AIM-1 and our sampling strategy in AIM-2 could both adapt as information accumulated. So click, please. The first wave I called a pilot. It was very small. We took just 4 patients and we chose them based on those 4 strata of did you engage in care, yes, no, and allostatic load above and below the median. We used these 4 to do 2 main things. The first was to establish, to test our audit protocol. We had the auditors look at these first 4 records, and then we met with them to get their feedback on what's working well, what could work better. Is there something that we could kind of change about the tools that we're providing, which was very helpful. We also had all of the auditors review the same 4 records from this pilot. And we did that so that we could establish inter-auditor agreement. Down the line, they're going to split up the records, and auditor A might do the first half, auditor B might do the other half. But at the end of the day, we want to be able to defend the fact that these auditors review data equally well and are effectively interchangeable. And so the pilot was a nice way for us to intentionally select data to do that. Next click, please. Thank you. So the next was wave 1. This is where we actually started to get into the strategy and kind of collect a lot more data. And so we took 48 people in wave 1, and they were chosen by that balanced case control sampling as well. We didn't want to throw kind of too much at it at wave 1. So basically there's a trade-off here. We didn't yet know which strategy would be the best, and we didn't want to spend a bunch of our resources at wave 1 only to find down the line that maybe we should have adjusted the strategy. So we basically split up the remaining records. And so we were able here to collect initial audit data, and we used that initial audit data to conduct what we called bespoke simulation studies. We basically considered a bunch of different scenarios coming out of wave 1 so that we could determine which of these potential audit designs was actually expected to be the most informative or the most helpful going forward. Click, please. Which, after those simulation study designs, in wave 2, we decided to collect the last 48 patients via residual sampling from that naive model like I described. And this was because we found that under low error rates, which is what we experienced, the naive model really isn't that bad. And also the residual sampling design was quite a bit more helpful than any of the stratified designs. Next slide, please. And so our AIM-1 was to establish an audit protocol. I've summarized part of it here. Basically, we took each of those thresholds that were given for the components of the allostatic load index. Thank you. And our clinical collaborators identified in all but one case some potential sources of auxiliary information. For example, if a patient was missing their systolic blood pressure, then the clinical collaborators believed that a diagnosis of hypertension provided enough information to assume that this person probably would have had a systolic blood pressure above that threshold. And so based on, we called this the audit roadmap. Based on the audit roadmap, we devised an audit protocol where auditors were asked to do kind of one of two things. So it depended on, first, if the component was non-missing in the extracted EHR data. So if there is an observed triglycerides in that row of the data that they're looking at, then they're asked to go and verify whether the value in EPIC matched. Now, based on whether or not it matched, the auditors could essentially enter one of three things. One finding is that the extracted value was correct. What we have in the extracted data matches what we had in EPIC. The second is it was incorrect. The third is that they actually couldn't find it. So it's in the extracted, but it's not in the other. And then for missing components is when they look to this roadmap. So if it wasn't observed to begin with, but you could find one of these supplementary diagnoses, then you would enter that information as well. Next slide, please. And so based on this audit protocol, we're now kind of at that stage between wave 1 and wave 2, which is what I'll talk about. And so Joe talked about the missingness for a lot of different components before, but I'll take you through just a few. So click, please. These are the 10 components of the allostatic load. We see that rare labs are commonly missing together. This is creatinine clearance, homocysteine, and C-reactive protein. Click, please. We also see that another 474 patients are missing those labs, plus hemoglobin A1C and cholesterol. And click, please. There were some variables that are not missing for basically everyone, and these are the routine ones like BMI and blood pressure. Now, while dire, click, please, I will note that the majority of patients, 78%, were missing fewer than half of their allostatic load components. So we did have a good amount of information for most people going in. Click, please. And so just some descriptive statistics on healthcare utilization to start. So of the 1,000 patients in our study, 318 of them, so like 32%, engaged in the healthcare system at least once during the study period. Of those that engaged, most engaged at least once or twice, but there were some who engaged up to like 46 or 25 times, like just one person. We are looking at this right now as a binary of did you engage at all? Yes, no, but looking at this more granularly, for example, with like a negative binomial or Poisson regression is definitely a future direction. And so just to look at the relationships based on the original data, patients who had at least one hospitalization or ED visit had a slightly higher allostatic load on average, but if you look at the distributions, there is quite a bit of overlap. And they were also slightly older at the study start, but again, there's a good bit of overlap there as well. Click, please. And so we were able to do some preliminary models for healthcare utilization. So the first one I'll show is what I'll call the naive model. This is using all 1,000 patients, but it's using the unvalidated data. And we see, we expect a pretty low odds of engaging in the healthcare system to begin with for people who were of average age and had, in this case, an allostatic load of 0, meaning like they'd experienced none of the components. Now, the piece we were really interested in is the odds ratio on the allostatic load, which we've rescaled to be a 10-unit increase or like a 1-component increase, which we do find here based on the naive is expected to change their odds of engaging in the healthcare system by a factor of 1.1 with that 95% confidence interval there. Age is also maybe related, but the confidence interval is a bit wider. Click, please. So then one other option would be just to focus on the validation subset. So we did have to do some inverse probability weighting here because of the way we chose people. But we could now focus and fit the same model on just validated data for the 100 people in the subset. And here, maybe the chief thing to notice is that the odds ratio on the allostatic load is much, much bigger. So this is looking at changes of in the order of like 1.5 times per component increased in the odds of engaging in the healthcare system. This is to be expected because I think of the way we chose people, we kind of intentionally chose people to make sure we had a broad range of allostatic loads, and quite a lot of people had auxiliary information found, which means that their validated allostatic loads are bigger than their unvalidated allostatic loads. Next slide, please. And so finally, with partial validation, we use that kind of missing data approach, and we're able to combine the unvalidated data on 900 and the validated data on 100 people. And we find that our estimates achieve kind of a happy medium. So our estimated odds ratio is 1.21. It's a good bit bigger than the unvalidated one, but smaller than the only validated one. And our confidence interval is a lot narrower than the complete case analysis because we're borrowing information from those remaining unvalidated people. And with that, it's back to you, Joe.
Am I muted? Okay, great. Thank you. Oops, wrong button. Sorry, guys. Okay. Thank you, Sarah, and thanks everyone again for your attention. So with everything said so far, I think there are a lot of ways we could go. So the first way is we're going to publish this paper detailing the odds ratio findings that Sarah was getting into in the last few slides. One place I initially wanted to go with the first pilot was, could we create visualizations spatially? With this ALI metric in hand, could we look across what was then the system and maybe now is much larger, including the Midwest and the Southeast? Could we calculate this metric at scale, sort of like what is being done for EFI? Could we identify hotspots of poor ALI and try to understand what's going on there? Could we look at differences in ALI by sex, gender, race, ethnicity, socioeconomic status, and caregiver burden? Could we identify trajectories over time where ALI is improving or worsening and try to understand features of the environment that may be impacting that? So ALI could be a really useful outcome, or it could be a useful predictor if we were able to operationalize it. We could pilot interventions to reduce it because it's more likely to move in the short term than some of these indicators or some of these chronic disease outcomes. We could also create what I think are kind of cool data visualizations, almost like a video game metric or something of how much burden each person has across the 5 systems, just as a visualization, perhaps even in their chart. And then I think what's the most interesting of all, and I think has the most legs moving forward, hopefully, is this validation process we're starting to establish on the EHR data. Could we develop a standardized process for improving EHR data quality using, using computers and humans essentially, but basically leveraging bullet point 4 here, that we have a group of trainees in medical school or residency or fellowship who are used to doing chart review and expecting to do so as part of their training. Could we leverage that expectation and that readiness for chart review in this data-driven fashion to inform some of the most important research questions across the system using this validation protocol approach? And then with each successive project, as we've done in this project, we're going to learn about missingness and errors in the EHR, and possibly at some point standardize this practice into a best practice partial validation protocol, make these tools and methodologies available across the system, and then also think about best practices for study design and data analysis. So these are not easy. This is sort of way down the road, but this is where my mind goes after learning about this process and how it can be useful in studying research questions. So I think with that, we're going to leave some time for Q&A. And as I promised, we have references at the end here. This is kind of the background on some of the health information in the country and Blue Zone emerging research. And then this slide is more statistical, where we get into some of the details of those likelihoods Sarah was showing, and then how people are using partial validation in other contexts as well. So let me stop there and leave time for Q&A. Thank you for your attention.
Thank you very much. I would like to clap on behalf of everybody, Dr. Rigdon and Dr. Lotspeich. This was a really interesting study, and thank you for presenting it. And then for our audience, if you have any questions, please put them in chat, and then I will be reading those questions to our speakers. So let me start by asking. Marty usually has a question, but do you have a question, Marty?
Actually, a couple. Just
Okay.
Hey,
I could guess that you were going to ask. So
hey,
before I
Martin.
ask my question,
So-
why don't you go ahead, introduce yourself and then your background, and then ask your question.
Okay, Marty Cohen. I'm adjunct faculty at the Center for Artificial Intelligence Research. My background is I am a physician, practiced emergency medicine for 30 years. I'm a biomedical engineer, formerly chief medical scientist at IBM Research, and also a background in health policy and management. So just the first couple of comments, apropos of you're looking at healthcare utilization, there is an evolving concept in healthcare that I think fits in with some of what you're doing beyond longevity and lifespan is the concept of health span. Now, since I am solidly into the over 65 age group that you have identified, I am particularly interested in this. And the idea is eventually each of us will acquire various chronic diseases. Eventually, we will all die. As my friend Eric Topol is fond of saying, life is the one uniformly fatal sexually transmitted disease. And there is some theoretical argument that 130 to 140 is actually the maximum lifespan, because at that point, studies show that cells stop reproducing, and that may be the end. So the goal would be help each of us live to that maximum expectancy, but relatively healthy. And the corollary policy concept with health span is morbidity compression. We are all going to get these bad diseases, or some of them eventually. Wouldn't it be better, instead of lingering with infirmity and disease for decades, make it to 130 and then the end comes within a year? So, all of those are things that are part of current research and interest in aging, with the idea of making aging healthier rather than accepting aging and infirmity as synonymous. And so, the idea of identifying who's going to use healthcare facilities is important. But what I'm more interested in is what can we do to reduce the likelihood that they will actually need all that. And it seems like involved in your analysis is the potential for that. So finally, after my long introduction, that's the question.
Yeah, I think health span, thanks for that background. It's certainly a goal of probably all of us. And I think frailty is a really important metric of that. And I think part of our motivation was knowing that the frailty concept, at least to date, I believe has only been studied in individuals 55 or 65 and older. Is there sort of a leading indicator of that, a different type of a metric that's similar in spirit, but maybe more designed for the general adult population that we could track earlier on and possibly improve as a prevention step in avoiding some of these frailty deficits down the road? And we were thinking ALI could be that metric based on some of the previous research that's been done before. And it could serve as an outcome that could be targeted and possibly improved in individuals who are less than 55 to 65, and then leading to improvements down the road. But to be able to move it, and we were going to first have to be able to measure it. And so the project started with this view of how do we improve health span? We need a metric to do so. Can we use this incredible resource of EHR data? But in thinking of creating the metric, we ran into all these measurement error challenges. And so that was really what the partial validation is about. Is it's a strategy to try to measure this metric of health span.
Interesting, because we are trying to embark on a related project with, you mentioned earlier, is looking at longitudinal healthcare trajectories, and what is part of the earlier trajectory in patients that are healthier as they get older? And how does their healthcare experience, their healthcare trajectory differ from those that, that acquire chronic diseases earlier, including, all the different things that can influence that. So we're kind of putting together a grant application for that now, just to study that. Again, it's my personal bias is, I want to keep on being healthy. What can I learn from people who have lived to 110 in good shape that I can apply, or that in retrospect, as a physician, I can recommend to younger people who have that same goal.
Exactly. We were starting along the same lines at the beginning of the project is, these 9 themes in these blue zone places: natural movement, sense of purpose. There are investigators probably across the whole system who are thinking of interventions in each of those spaces. And could we pilot test interventions and see how they move the ALI, which has been shown to be a predictor of downstream longevity and health outcomes? So I think I'm kind of intervention agnostic. Like I as a statistician, I'd love to measure and test whatever anyone comes up with. But the ALI could be an avenue to do so.
Well, I think this is a good start. My suspicion, and sort of supported by some of the earlier research, is it's going to take more than EHR data to accomplish that task.
Yeah.
As many studies have shown, is involvement with the healthcare system accounts for less than 20% of the improvement in health over the last century. So clearly we need to be looking at other things too, to become more comprehensive.
That's a great point. I'd love it if you could send me that reference of the less than 20%. I have a lot to learn about that. Yeah.
I'll see if I can dig up there are several of them. I'll try to find one.
Thanks so much.
Thank you, Marty. This was a really nice and engaging conversation. And I think you asked some of the questions that were in people's minds. So this is really, really exciting. When you were talking about blue zones, I realized that the town I was born and grew up is only a few hours away from one of the blue zone areas, but my hometown is not known as a blue zone area. I think it's related to the socioeconomic conditions that you talk about. So I'm very, very happy to see that your future work involves looking at the socioeconomic conditions. And I think you will find that is going to make a big difference. And then I look forward to hearing more about your new results with that work. And I think it's going to be really exciting. We are at the end of our allocated time. I want to thank you again, Dr. Rigdon and Dr. Lotspeich, and then clap on behalf of everybody. Thank you, everybody, for joining our IA seminar this afternoon. And thank you, Marty, for really exciting and insightful questions and comments that you brought. Have a nice afternoon. Bye-bye.
Thank you all.